Usually, when we talk about a medical diagnosis, there's this expectation of like mechanical precision.
Right, a very clear-cut problem.
Yeah, exactly. Like you break your arm, the x-ray shows a jagged white line, and the doctor just points to it.
The problem is visible, it's localized, and, well, undeniable.
But, step into the world of pregnancy, specifically the way maternal blood pressure is monitored and handled, and suddenly you are basically navigating in the dark.
It really is a whole different ballgame.
It is. And that's why today we are taking a really comprehensive look at hypertensive disorders in pregnancy.
It's a critical topic.
So our mission for this deep dive is to decode the mechanics, the hidden risks, and honestly, the highly surprising treatments of a condition that affects up to 10% of all pregnancies.
Which is a huge number when you think about it.
It's massive.
Yeah.
And we're moving far beyond the simple idea of just high blood pressure to understand what is truly happening at a cellular level inside the body.
Because that cellular level is where the real story is.
Right. And whether you are, planning a family, currently pregnant, or supporting a loved one, understanding these invisible physiological changes is the ultimate shortcut to advocating for better medical care.
Absolutely. Advocacy starts with understanding the mechanics.
So let me just drop two facts right out of the gate here. First, that electronic blood pressure machine you see in almost every hospital room, it might actually be giving artificially low or high numbers compared to a traditional manual cuff.
Oh, the machines can definitely be misleading.
Yeah. And second, that classic doctor's advice of strict bed rest for pregnant women with high blood pressure, it's completely outdated.
What's fascinating here is that we often view these disorders as, like, isolated cardiovascular glitches, almost like a temporary plumbing issue.
Right, like a leaky pipe you just patch up.
Exactly. But they are essentially a progressive, systemic chain reaction. Catching the subtle clues before they snowball is the literal difference between a routine birth and a massive medical emergency.
Okay, let's unpack this. Because to really treat the condition, we have to look at the distinct categories at play here.
We do. It's not all just one blanket diagnosis.
Right. So we have chronic hypertension, which is high blood pressure that is present before pregnancy or before the 20-week mark.
Mhm.
And then there's gestational hypertension, which is new high blood pressure emerging after 20 weeks. And then we have preeclampsia.
Yes. Preeclampsia is the primary driver of the most severe complications, and it's entirely unique to human pregnancy.
That's wild. Entirely unique to humans.
Completely.
Yeah.
And the root cause isn't the mother's heart, her baseline diet, or even her inherent vascular health.
Wait, really? Then what is it?
The root cause is a highly specialized temporary organ, the placenta.
The mechanics of how this starts are just wild because normally when a pregnancy begins, the spiral arteries in the uterus undergo this massive structural remodeling.
Right, they have to physically change shape.
Yeah, they widen from these thick, rigid muscular tubes into thin, highly flexible sac-like vessels.
They do this to handle the massive influx of blood volume that's required to support a growing fetus.
But in preeclampsia, this vital remodeling process, it just partially fails. The mother's vessels remain narrow and rigid.
Which essentially starves the placenta of adequate blood flow. This is a state called placental ischemia.
So the placenta is literally gasping for air.
Basically, yes.
Mm.
And when the placenta is underperfused and panicking for oxygen, it releases this whole cascade of substances into the maternal bloodstream.
And these aren't just like random distress signals, right?
No, they act as actual toxins. They aggressively target and damage the mother's endothelial cells.
And those are the delicate cells lining the inside of like every single blood vessel in her body.
Every single one. It's systemic.
It sounds like the placenta is trying to install a high-capacity fire hose for the baby, but the mother's body keeps the standard plumbing.
That is a perfect way to look at it.
And the intense pressure and the toxic cellular debris just, wreak havoc on the pipes.
They really do.
Yeah.
When those endothelial cells sustain damage, the immediate physiological response is generalized vasospasm.
Vasospasm. So the vessels are just freaking out.
Exactly. All the blood vessels in the mother's body begin to forcefully constrict and spasm. And furthermore, because the inner lining is compromised, the vessels actually lose their structural integrity.
Meaning they become leaky.
Yes, highly leaky.
Okay, so if the placenta is the sole root cause triggering all this chaos, does the disease just instantly vanish the second the placenta is delivered? Or is there like a dangerous lag?
That's a huge misconception. Delivering the placenta removes the source of the toxins, sure.
But it doesn't just flip a switch back to normal.
No, it doesn't instantly repair the structural damage to the maternal vascular system. The leaky vessels, the lost plasma volume, the widespread endothelial dysfunction that takes real time to heal.
So the risk doesn't just end in the delivery room.
Far from it. The risk of severe complications remains exceptionally high in the days immediately following birth. Symptoms can, and frequently do, appear for the very first time during the postpartum period.
Wow. And because the mother's pipes are spasming and leaking fluid into the surrounding tissues, the damage doesn't just stay local to the uterus, it systematically attacks major organs.
It's a full-body assault, really.
So how does this fluid shift manifest before the blood pressure even spikes?
Well, the fluid shifting out of the bloodstream causes hemoconcentration.
Meaning the blood literally becomes thicker.
Thicker and much more viscous, and because of that, the kidneys take a massive hit. Their filtration vessels are spasming, so they can't clear waste properly.
Which leads to oliguria, right? A severe drop in urine output.
Exactly. Oliguria and a very dangerous buildup of uric acid in the blood.
Man. And it hits the brain, too. I read we see severe frontal headaches and visual blind spots, which are clinically known as scotomas.
Yes, scotomas. That is the central nervous system becoming inflamed and highly irritable due to cerebral swelling and poor blood flow.
And then there's the liver.
The liver is extremely vulnerable here. Reduced perfusion stretches the liver capsule, which results in severe pain in the right upper quadrant of the abdomen.
Which leads us directly into a terrifying variant of this condition, which is HELLP syndrome.
HELP syndrome is a true obstetric emergency.
So HELLP stands for hemolysis, elevated liver enzymes, and low platelets. Let's look at the mechanics of why that actually happens.
Let's start with hemolysis. That is the physical destruction of red blood cells.
Because the blood is so thick.
Yes. As viscous blood is forced under high pressure through spasming damaged vessels, the red blood cells are literally physically sheared apart.
Ugh, that sounds awful. And the low platelets.
Well, the body detects thousands of micro tears across the entire endothelial lining of the vascular system.
So it sends out the repair crew?
Exactly. It deploys platelets to patch up all those leaks, rapidly depleting the body's entire supply.
It is an incredibly dangerous state. It carries a 70% preterm birth rate, yet somehow it is frequently misdiagnosed.
That's the scariest part.
Wait a second, though. If HELLP is a severe variant of preeclampsia, but a woman doesn't present with sky-high blood pressure or protein in her urine, isn't she just going to be sent home?
Unfortunately, yes, that happens far too often.
Because, nausea and upper abdominal pain, that sounds exactly like a stomach bug or food poisoning.
This raises an important question about our diagnostic criteria. Relying on blood pressure alone is a dangerous trap.
Because the numbers don't always match the internal damage.
Right. 15 to 50% of HELLP cases present with only mildly elevated blood pressure. Over 10% have absolutely no protein in their urine.
That is terrifying.
So medical professionals have to look for the subtle systemic clues. A sudden abnormal weight gain from tissue fluid retention, or that highly specific epigastric pain, or an unexplained drop in blood platelets on a routine lab draw.
If the symptoms are that deceptive, let's look at how medical professionals actually assess this. We mentioned the electronic blood pressure machines at the start of the deep dive.
We did, and they are a huge point of contention.
The data shows they consistently underestimate diastolic blood pressure by about 10 millimeters of mercury, and they overestimate the systolic by 4 to 6 points.
Which is a significant margin of error in a high-stakes scenario.
If these hospital cuffs are off by a whole 10 points on the diastolic, shouldn't we be throwing them out of the maternity wards entirely?
It comes down to understanding the limitations of automated equipment in a spasming vascular system. The machine just gets confused by the spasms.
So manual cuffs are still the gold standard.
Manual cuffs and a stethoscope are absolutely critical for verification when a patient approaches the threshold for severe hypertension.
But you can't just obsess over one number.
Exactly. The clinical focus must prioritize the overall trends rather than obsessing over a single isolated reading. A slow, creeping upward trajectory tells a much more accurate story of the disease progression than one automated snapshot.
Okay, so since the blood pressure readings can be so murky, the physical exams become the real detective work here.
They are essential.
To check for all that fluid leaking out of the damaged vessels, clinicians check for pitting edema.
Right, where they press a finger into the swollen tissue of the ankle or leg.
Yeah, and it leaves a physical indentation that can take up to 30 seconds to fill back in. And they grade the severity from +1 to +4. But they also assess deep tendon reflexes and ankle clonus.
Yes, checking the reflexes is a direct window into the nervous system.
So assessing clonus involves sharply pushing the foot back toward the shin, dorsiflexing it, and then releasing it.
The clinician is looking for rhythmic, involuntary jerks of the foot as it relaxes.
It's like tapping a microphone to see if the central nervous system's amplifier is turned up way too high.
That's a great analogy.
Yeah.
The swelling and ischemia make the nerves hyperreactive.
And the medical understanding of how to interpret all these signs is shifting really rapidly, right?
It is. A perfect example of that evolution involves proteinuria.
The protein in the urine.
Right. Historically, having over 5 grams of protein in a 24-hour urine collection was a primary diagnostic criterion for severe preeclampsia.
But not anymore.
No. The American College of Obstetricians and Gynecologists actually removed massive proteinuria from their severe features list.
Really? Why?
Because the sheer volume of protein simply didn't reliably predict the severity of the outcome for the mother or the fetus. It was a distraction, essentially.
Wow, so instead, researchers are hunting for predictive biomarkers in the blood.
Yes, looking at the molecular level.
They are measuring levels of a protein called PLGF, which promotes healthy blood vessel growth, against levels of SFLT1, a protein that restricts vessel growth.
It's a delicate balance between those two.
And high levels of the restricted protein combined with low levels of the growth protein can actually predict the onset of preeclampsia weeks before any physical symptoms ever manifest.
We're seeing a gradual transition from reactive management to predictive medicine, which is incredible.
But currently, once preeclampsia is detected, or if a patient is flagged as high risk, the clinical approach becomes a highly delicate waiting game.
It's incredibly stressful because the only definitive cure is delivery.
So management is purely about buying time safely so the fetus can mature.
Exactly. Every extra day in utero counts.
For high-risk women, the preventative measures often start between 12 and 28 weeks with a daily low-dose aspirin, just 81 milligrams.
A simple baby aspirin, but it does wonders for the endothelial inflammation.
And the guidelines for who qualifies as high or moderate risk are extensive. They include histories of chronic hypertension or autoimmune diseases, but they also incorporate factors like utilizing in vitro fertilization.
Yes, IVF alters the initial placental implantation process, which increases the risk.
And demographics, such as being Black or having a low income, are also considered moderate risk factors prompting aspirin use.
Right.
And those act as clinical proxies for underlying systemic and environmental inequities that impact overall health outcomes.
It's about recognizing that chronic stress and systemic barriers take a physical toll on vascular health.
Definitely. So when cases are classified as mild, management typically involves restricted activity at home. But crucially, complete strict bed rest is no longer recommended.
It's a huge pivot in obstetrics.
Why the shift, though? Because for decades, strict bed rest in a dark room was the absolute gold standard for high blood pressure in pregnancy.
Well, the clinical data ultimately showed it just didn't improve pregnancy outcomes.
Wow, all that suffering for nothing.
Pretty much. What it did cause was muscle atrophy, increased risk of blood clots, immense financial strain, and profound psychological stress.
And we probably just made the blood pressure worse.
Exactly. So the current protocol encourages low-stress, restricted activity. It allows the patient to maintain mobility and a better quality of life while they're waiting.
Here's where it gets really interesting, though. When a case escalates from mild to severe, the primary intervention is an intravenous infusion of magnesium sulfate.
Yes, the mag drip. It's notorious in labor and delivery wards.
And most people intuitively assume this is administered to force the dangerous blood pressure down.
But it actually has very little effect on maternal blood pressure.
Which is so counterintuitive. It is used specifically to prevent the mother from having an eclamptic seizure.
That is its primary critical function.
Oh wait, magnesium sulfate works by relaxing smooth muscle tissue. And the uterus is essentially one giant smooth muscle.
It is.
So, doesn't pumping a pregnant woman full of a smooth muscle relaxant completely stop her from going into labor?
It seems completely counterintuitive, I know, but the pharmacology relies on highly targeted dosing.
Ah, so it's all about the amount.
Right. At the specific 4 to 6 gram loading dose, followed by a steady maintenance dose, magnesium sulfate manages to protect the cerebral circulation and prevent the brain from seizing without significantly halting uterine contractility.
That is amazing.
It may cause a brief relaxation of the uterus when the initial loading dose hits the bloodstream, but it does not stop the overall progression of labor.
The body's receptor thresholds are just incredibly finely tuned.
They really are. And as a safety net during this infusion, medical staff monitor the patient constantly.
Right, because if the toxicity gets too high, meaning her reflexes disappear entirely or her respiratory rate plummets, the immediate antidote is calcium gluconate.
They keep it right there at the bedside.
And if her blood pressure does cross the threshold where she's at imminent risk of a stroke, they administer targeted antihypertensives concurrently, utilizing drugs like labetalol or nifedipine to physically lower the pressure.
Because the magnesium sulfate won't do that job for them.
Right. But if those preventative measures fail to hold the line, or if the disease simply progresses too rapidly, preeclampsia escalates into eclampsia.
Which is the absolute worst case scenario.
That transition is marked by a severe seizure,
The eclamptic seizure manifests as a massive tonic-clonic convulsion.
meaning the muscles contract rigidly, followed by violent jerking.
It's terrifying to witness. The immediate nursing protocols demand that medical staff never leave the bedside.
They pad the side rails to prevent bone fractures, secure a patent airway, and administer additional magnesium sulfate.
And notably, they strictly avoid using traditional anti-seizure drugs like diazepam,
Why is that?
because diazepam depresses the gag reflex. In a pregnant patient, that drastically increases the risk of the mother aspirating stomach contents into her lungs.
Man, managing that acute emergency sounds harrowing.
It requires an incredibly coordinated team effort.
But the critical pivot in modern maternal care is recognizing that even after a successful intervention, even after the baby is safely delivered and the mother's blood pressure stabilizes, her cardiovascular narrative is far from over.
This is perhaps the most important shift in our understanding of the disease.
The long-term rules are literally being rewritten. There was this massive 2022 trial called the CHH study.
The chronic hypertension and pregnancy study, yeah.
Right. It upended decades of medical protocol. Because previously, if a pregnant woman had mild chronic high blood pressure, clinicians often chose not to treat it pharmacologically.
They assumed the medications wouldn't significantly change the outcome for the baby, so why risk the side effects?
But the SHARE study proved that actively treating patients at the much lower threshold of 140/90 significantly reduces the rates of severe preeclampsia, placental abruption, and preterm births.
It shifted the global standard of care overnight. It emphasized that early aggressive management of even mild vascular stress protects the physiological integrity of the pregnancy.
It also reframes how we view the aftermath of the disease. Women who experience preeclampsia carry a significantly increased risk for developing chronic hypertension and severe cardiovascular disease later in life.
It's a huge red flag for their future health.
So basically, preeclampsia operates like a massive 9-month-long cardiac stress test.
That is exactly what it is.
It reveals a woman's hidden cardiovascular vulnerabilities decades before they would normally show up on a cardiologist's radar.
If we connect this to the bigger picture, the condition acts as a physiological crystal ball. And this is why postpartum monitoring cannot just be about checking a healing incision or assessing basic recovery.
It has to be more comprehensive.
Immediate lifestyle education focusing on maintaining cardiovascular health, targeted physical activity, and lifelong blood pressure monitoring is now viewed as a mandatory extension of maternal care.
So the delivery is the end of the pregnancy, but it is really just the beginning of her cardiovascular management.
Precisely. We have to look at the long game.
So what does this all mean for you listening right now? We've navigated an incredible journey through the mechanics of maternal health today.
We really covered a lot of ground.
We established that pregnancy hypertension is a complex placenta-driven endothelial disease, fundamentally altering the mother's vascular plumbing.
It's not just a number on a chart.
No. We uncovered that assessing the irritability of the central nervous system through reflexes and checking ankles is just as vital as trusting a blood pressure cuff that might be feeding you inaccurate numbers.
The physical exam is paramount.
We learned that magnesium sulfate is an emergency brain saver, not a blood pressure reducer.
A very common but critical misconception.
And we explored how the recent CHF study has rewritten the protocols on exactly when to intervene.
Understanding these mechanisms fundamentally changes how a patient navigates the medical system.
It arms you with the context to ask your physician highly specific questions.
It illuminates exactly why a simple 81 milligram aspirin might be the most crucial preventative tool you utilize.
And it makes it abundantly clear why a lingering, severe headache weeks after bringing a baby home requires immediate medical intervention, not just a painkiller.
You have to listen to what your body is signaling.
Because we are not looking at a static, localized problem, we are looking at a highly complex, temporary physiological state that pushes a woman's body to its absolute limits.
It is the ultimate stress test.
Which leaves you with a final, lingering question to ponder. If the temporary presence of the placenta has the power to so radically alter a mother's entire cardiovascular system, trigger widespread endothelial dysfunction, and accurately predict her risk for heart disease decades into the future, what other hidden long-term cellular changes is fetal tissue leaving behind in the mother's body long after the baby is born?